Welcome to Chapter 19. We are getting into respiratory emergencies with this chapter. This chapter is where we're going to focus on a lot of the details that we didn't get to learn in our airway management chapter. So without further ado, let's get on with it. This is a brief overview of the topics that we're going to cover in this chapter. We've got respiration, which we already know a little bit about. We've got breathing difficulty and the definition thereof. Our respiratory conditions, that's all of the different situations where respiratory emergency happens. And then we have the prescribed inhaler and the small volume nebulizer, both of which are going to be things that as the EMT you are going to become very familiar with. So respiratory anatomy and physiology. We have to understand that in order to move air, the respiratory system changes pressure. Your lungs themselves do not have any muscles. So we rely on negative pressure to move air in, and then positive pressure moves air out. So that's how we get inhalation and exhalation, is through the contraction and relaxation of those respiratory muscles. So this is showing us a visual diagram of inspiration, and that involves your diaphragm, which is a big muscle that kind of cuts your abdomen off from your chest. So when that diaphragm contracts, it actually moves down into your abdominal cavity, and that's what creates that negative pressure inside of your chest so that air can come into your lungs. That's inspiration. And then as that diaphragm, as that muscle relaxes, it moves up into your chest cavity, and that's where your passive expiration begins. This is just talking about some more of the details about how inspiration itself actually works. We mentioned that the diaphragm itself contracts, but it's not the only sort of system involved. We also have your intercostal muscles, and as you remember from A&P, your intercostal muscles are all of those muscles in between your ribs. So those muscles are also going to contract, and as your diaphragm contracts, it increases the size of your chest cavity. So your diaphragm gets lower, your intercostal muscles tighten up, and that's what actually moves your ribs upwards and outwards, and that's how that air gets pulled in. Okay, so where inspiration was an active process, i.e. your muscles have to contract in order for that to happen, expiration is a passive process. So everything just sort of relaxes and air flows out. It's basically just the opposite of inspiration. Now we're going to get into some of the details about breathing itself. So adequate breathing is only breathing sufficient to support life. So what that means is that it has to be breathing where your patient is talking to you, they are conscious, they're oriented, that's that normal mental status. They have the ability to speak without any dyspnea. They don't have to catch their breath every third or fourth word. They're nice and pink. That's what we want. We also like to see good O2 levels in that normal range. So obviously sometimes you may have a patient that just ran up a flight of stairs to meet you, but on the whole, when we talk about, normal rates and rhythms, we are talking about patients that are at rest. So at rest, a regular adult, a normal adult, will have normal breaths between 12 and 20 breaths per minute. So then that changes a little bit as we get younger. When we're talking about school-age kids, that's going to be 18 to 30 breaths per minute. Proportionately speaking, their lungs are much smaller, so they're going to breathe a little bit faster. That doesn't make it bad, it just makes it faster. So then infants are going to breathe infinitely faster, up to 60 times per minute. So that's one breath every second. That seems like a lot, and that's going to seem like hyperventilation, but it's not for an infant, not for a newborn. Also, people are going to breathe pretty regularly. Obviously, if they're talking, their breath might be a little bit, you might not have exactly the same number of breaths in a minute, but the rhythm is going to be pretty regular. And then also we have those breath sounds that we learned about in our patient assessments and our vital signs, where we're going to have breath sounds that are normal on both sides. Now we're going to get into the spicy stuff. This is inadequate breathing. This is breathing that is just not going to support life. So our signs of that where our rate is outside of that normal range. So remember back to the last slide, what our normal range of breath rates are per minute. We're either going to be way too fast or we're going to be way too slow. And sometimes that irregularity is going to play a big factor. Also, inadequate breathing is not going to give people the ability to speak. People with inadequate breathing are not going to be talking. They're not going to be able to draw enough breath in order to form words. And also when you go to listen to their chest, you're not going to hear any breath sounds. There's going to be no air movement in there. More of those signs of inadequate breathing, right? We're going to see that low oxygen saturation. Even if we already have them on supplemental oxygen, you're still not going to get that saturation level up. This mentions agonal respirations, but that's that gasping, respirations, that gasping type of breathing. That's just a precursor to breathing stopping altogether. So that's not going to be necessarily the only irregular respiration that you might hear with inadequate breathing. We're also going to get things like stridor, things like snoring, gurgling. You might hear a crowing sound. While those are breath sounds, those are not lung sounds. So you can still have breath sounds and diminished or absent lung sounds. Those are two separate things, and we need to bear that in mind. The other important thing is we're going to get that irregular rhythm. You might have a patient who takes a breath and then 30 seconds goes by, and then they take 2 more breaths back to back, and then you get 15 seconds between breaths. Like, that's very irregular, and that's just not sustainable to life. We're also going to see that poor tidal volume, that overall amount that we can actually get in. When we talked about normal rates and rhythms for different age groups, we also made note that pediatric patients tend to breathe much faster than adult patients. Well, so now we're going to learn about why exactly that is. So it actually comes down to structure of a small person's head and throat and chest. If you remember back, if you've ever seen a picture of a baby, they're like a third head. And then as they get older, it gets more proportional. Well, that proportionately bigger head, smaller body also means that their airway is smaller, proportionately speaking. They have a larger tongue. The trachea, the back of the throat, is going to be softer and smaller and more flexible. And that, paired with the fact that all of that cricoid cartilage in the front there isn't as rigid, means that they are not as able to protect their airway as an adult is. Children and peds also tend to have a pretty heavy dependence on diaphragm for respiration. And what that means is you can watch a baby breathe based on their belly movement. They do a lot of belly breathing and not so much chest rise. So we need to that's something to pay attention to. So a baby will breathe with their bellies, and that's normal. And if a baby starts to breathe with their chest, that is actually considered abnormal for babies. So something to pay attention to, something to make note of. Since pediatric patients tend to have such a different rate and rhythm of adults, kind of a handy way to think about inadequate breathing in infants and kids is the actual mechanics of the way that they're breathing. So if a child is having difficulty breathing and it's inadequate, you're going to see nasal flaring where they're using everything they can to get air in. You're also going to hear them grunting. They're going to grunt with each breath because it's literal effort to get it in. Seesaw breathing is where, we talked about in the last slide where they're belly breathers. So seesaw breathing is actually where you're going to see that belly go up with their breath in, but then you're going to see their chest go up with their breath out, where they are using their belly muscles to force that air in and out. And it's pretty easy. That's why they call it seesaw breathing. It's pretty easy to identify. The other thing you're going to see is retractions, and retractions are going to be noticeable in between the peds' ribs, where those intercostal muscles that are supposed to be, pulling the ribs up and out, you're actually going to see them contract in between the ribs because they're just trying to use every muscle they can to breathe. So let's get into what to do if we have diagnosed inadequate breathing. Okay, So obviously, we are going to assist ventilations on these patients. If we're going to assist ventilations, we are giving that supplemental oxygen. We already know what our oxygen levels should be. We know what those ranges are. So we would like to assist ventilations in order to get back to that proper level. A couple of different ways that we can do that. We have the pocket face mask with supplemental oxygen. That is an option. We also have 2 rescuer bag valve masks. So remember back to your CPR training, that's what we're doing here. And then we also have the 1 rescuer bag valve mask. Again, we learned about that in our CPR class. Always with that supplemental oxygen. If our breathing is inadequate, then we are either mechanically not getting air in, or we are not exchanging the oxygen at the cellular level. Okay, so either way, we're going to need that supplement. Once again, as we learned in our CPR class, when we give artificial ventilation, we're going to see that chest rise. We're going to wait for that chest rise, and we're going to wait for that chest fall with every single breath. And we need to check every single breath. That's your job. If you are giving ventilations, that is the way to check yourself, to make sure that you are giving proper, adequate artificial ventilation. We're looking at 10 to 12 breaths per minute for grown-ups. Even though normal breathing rates are 12 to 20 breaths per minute, this is artificial ventilation. So we're only looking for 10 to 12. And then for infants and kids, we're looking for 12 to 20 breaths per minute. Again, normally they may breathe faster than that, but this is artificial ventilation. So we only need to give 12 to 20 breaths per minute for infants and children. So if we have an adult patient that we are artificially ventilating, a nice way to make sure that we're doing it properly is to keep an eye on that chest rise, keep an eye on those O2 levels, keep an eye on those end tidal levels, what have you. But a pretty clear-cut sign that you are doing inadequate artificial ventilation is that an adult's pulse will go up. It will actually increase because they are no longer getting the kind of oxygen their body needs, so their pulse will go up to compensate. Conversely, in a pediatric patient, if you are ventilating them and their pulse starts to go down, that might be the indicator that you are inadequately ventilating them. Something to consider, if you have a patient and they were breathing just fine, and now you're going in for your secondary assessment or you're going in for your reassessment, how are you going to decide that they've gone from adequate respirations to inadequate? Are you comfortable being able to tell the difference between the two? And what is going to happen to your patient if that happens? So if your patient is breathing okay, and then you come back to reassess them and they are not breathing okay, what happened to the patient in that timeline? Bit different from adequate breathing and inadequate breathing. This is breathing difficulty. So this is the patient reports they are having difficulty breathing. So they may feel like it's difficult for them to take a breath. They may feel like they have to work harder to take a breath. That's not to say that the patient's vitals will reflect that necessarily. Every patient is an individual, and so they will have a broad spectrum of responses to this difficulty breathing. Okay, so we're going to start our patient assessment, right? We've gotten called for difficulty breathing, and the first thing we're going to do is jump in there and assess the patient. Does the patient have adequate respirations? Are they breathing in a way that is sustainable with life? Do they need artificial ventilation? Next, we move into our actual assessment. So now we're talking about OPQRST, right? We're talking about onset. When did you start having difficulty breathing? Where were you? What were you doing when this came on? Were you outside mowing your yard in 90-degree weather with 40-mile-an-hour winds? Or were you taking a nap and it woke you up that you weren't able to breathe? Does it get better when you sit down? Does it get worse when you talk on the phone? All of these have something to do with that provocation palliation question. So then we're going to talk about quality of the breathing. Do you have a cough? Is there anything in that cough? Is it very phlegmy? Is it normal for you? Do you normally have a dry cough? These are all part of our assessment questions. So now we're talking about radiation. Do we have pain? Is there pain with breathing? If there is pain with breathing, is it pain when we're with inspiration, or is it pain with expiration, or both? Do you have that pain somewhere else? If you take a deep breath, does your abdomen hurt? If you only breathe in very shallow ways, does that pain stay or does it leave? This is that we want to know if that pain is going anywhere. On a scale of 1 to 10, how bad is your breathing trouble right now? We also need to remember that that pain scale is also important. So if the answer to our pain question was, yes, I'm having pain, we also need that pain scale to rate that pain. This is how we judge for those changes. So maybe you have your COPD patient who doesn't breathe very good regularly. So maybe they would say that regularly their breathing is a 5 on a scale of 1 to 10 for how bad is it. But now today they feel like they're at an 8. That is an increase in the severity of their difficulty breathing. And then along with the onset, when did this start? We also want to talk about how long has it lasted? Is it coming and going? Is it constant? Is there anything that, when we talk about our provocation palliation, is there something that's making this feel better? And how long does that last? Does laying down make you feel better? Does sitting in your armchair make you feel better, but it only lasts for 10 minutes? That is a noteworthy thing to ask a patient. We're also going to take into account all of our regular observations. So are they altered at all? Do they appear to have cyanosis? Are they blue around the lips? Make note of any sort of unusual anatomy. Are they barrel chested? Sometimes you can note clubbed fingers. Even in this category, we're also going to include things that seem easy, but are they on home oxygen? Is there something wrong with their home oxygen machine? We also want to note the patient's positioning. Are they laying down? Do they appear to be comfortable? Are they sitting in an armchair? Are they in a tripod position with their hands on both knees because that's the only way they can get air in? Do they feel like if they're not leaning forward, there's a big weight on their chest? Positioning is important here. We also need to talk about the work of breathing. So how hard is it actually for them to breathe? Are they working hard to get a breath in? So this is when we're going to notice those retractions. We're going to notice the use of accessory muscles, those upper chest muscles, the abdominal muscles. These are not muscles we normally use to breathe. So if someone is using them, we know that they're in some distress. Again, we're going to notice those flared nostrils, pursed lips, where it looks like they're trying to whistle. It just looks like they're trying to draw air in through a straw. We may also see some spit gathered at the corners of the patient's mouth because they just can't take the time to swallow because it's so important for them to continue getting that air in. We also want to talk about any kind of dyspnea that's happening. So that's going to be when I ask them a question, are they able to respond, or do they need to take a break in the middle of their sentences to take a breath? Are they only getting 2 or 3 words out, or are they able to complete the whole sentence when they respond? Patient may also be very pale. If they're very pale, that may be when you start to notice that cyanosis on the fingernail beds, around the lips. However, they also may have very flushed skin. They may be super pink. This is the time when we want to check for swelling of the hands or feet. That can also be an indication of medical conditions that would limit their ability to breathe easily. So actual readable sign, we're going to see that O2 level low. We're going to see that less than 95 on our pulse ox. This is a really good picture of a patient who is experiencing difficulty breathing. So if you look, we're going to see those flared nostrils. We're going to see pursed lips. Obviously, if you have a patient of color, seeing that cyanosis might not be as readily apparent. But that's why we're checking those fingernail beds, maybe the lining of their mouth, their cheeks and their gums. They're going to have some tightness in that chest. Those are going to be those patient complaints, those symptoms. They're also going to use their face, their neck to breathe. Those are more accessory muscles that a patient might be using. The straining of intercostal muscles or abdominal muscles, like we mentioned already. They might have that cough. We might have a very dry cough. We might have a very wet, very productive cough. This is the tripod position that we were talking about. Hands on the knees, leaned forward. They may complain of some numbness or tingling in their hands and feet. That's going to be from that lower O2 level. We also may be able to hear them breathing. That's when we're going to get our respiratory noises. We're going to get the wheezing and the snoring and the stridor. You're going to see all of those, especially in patients when you walk in and they're in a tripod position. There are going to be times when you walk into a patient's house or into their hospital room or what have you, and be able to hear them breathing without your stethoscope, with no medical technology at all, no instruments. And if you can hear them from across the room, you know it's going to be messy when you get close to them. But this is more of those respiratory noises that we talked about. We have the gurgling, that snoring, that stridor, again with the cough. When you're auscultating a patient's lungs, just like we learned back in our vital signs, we want to make sure that we're listening on both sides, but during inspiration and expiration, because we want to be able to catch those lung sounds, those breath sounds on both, because they may only have wheezing on inhale, and then we can kind of already diagnose, oh, we know what that might be. If they're only wheezing on exhale, well, then we have a good idea of what that might be. So we've assessed our patient, we've assessed they're having difficulty breathing, we've confirmed it, they have whatever signs and symptoms we've recorded up to this point. So now we've looked at those patients' vital signs, we're reassessing, we're going back in for that secondary assessment. So at this time, their distress level is going to be really important. You're going to pay attention to their emotional level, how they're speaking, what they're saying, and then compare that with the vital signs on your monitor and what you're observing. When you auscultate a patient's lungs, you are going to get various lung sounds. Some of the more common ones, you're going to get wheezing. So that's specifically a high-pitched sound that happens when air is moving through a very narrow air passage. You're going to get sounds like crackles, which is a fine crackling or bubbling sound heard on inspiration. So it really does sound like you stuck your hand in a bowl of Rice Krispies. That is what those crackles sound like. So that is specifically caused by fluid in the alveoli or by the opening of closed alveoli. But in the field, you're mostly going to hear it when there's fluid involved. So this is going to be in cases like patients that have like pneumonia, for example. Next, you're going to have rhonchi. So your rhonchi is going to be those lower pitched sort of snoring sounds or rattling sounds. You can kind of identify these because you can sort of hear the thick secretions that air is having to move past. Sort of sounds like a swamp, like the bubbles that come up in a swamp. And then you have stridor. So a high-pitched upper airway sound is pretty easily identifiable because this almost always indicates some sort of a partial obstruction in the trachea or larynx. So this is going to be the 3-year-old kid that swallowed the quarter. You're going to be able to hear that super high-pitched sound when they breathe. So we've already been over that the important thing to pay attention to when we're assessing our patient is patient changes. In that, we're looking at changes in vital signs. So increased or decreased pulse rate. We already know if we're doing assisted ventilations, this is a good indicator of how good our ventilations are. But also, we're looking at changes in the patient's breathing rate. We're looking at changes in the patient's breathing rhythm. So we're going to learn a little more details about breathing rhythm. But if they were breathing very shallow and, 18 times per minute, and now all of a sudden they're taking 4 breaths a minute and it's irregular, that's a huge change that we need to pay attention to. We're going to track that blood pressure because hypertension or hypotension is a good indicator that something bigger is going on. In our diff breather patients, we've already done that assessment and we've already made sure that they are breathing on their own. They are able to secure their airway. They are able to breathe at a rate that is adequate, that is sustainable for life, right? So if we have to ventilate that patient, now we have to talk about making sure that we have adequate ventilations. Because if that patient's status changes, we may have to jump in. So if that patient's breathing is suddenly inadequate, we need to be ready to begin artificial ventilation. If that patient is comfortable and they're maintaining their own airway and it is sustainable, it's adequate breathing, we can go ahead and use that non-rebreather mask at 15 liters per minute or a cannula at 6 and keep that supplemental oxygen going. I just have a brief note about this slide because it definitely does say use settings as defined in your protocol. So that's going to be what ventilation, what oxygen supplementation levels we're at depending on the patient. And every service is a little bit different. Every area has their own specific protocols for these things. And I just wanted to mention that really quick here because they're not specifically going to tell you all of these in the book. And so I wanted to let you know that that's why. It's because every individual service has their own set protocols for this. One of the most important comfort care things that we can do for a diff breather is making sure that the patient is in their position of comfort. So when you come across the patient, if the patient says that they are only comfortable, that they can only breathe if they are laying on their left side, then unless there is a darn good reason to move them out of that position, then we are going to leave them there because that is where they are comfortable. Now, having said that, most difficulty breathing patients are going to want to sit up to some degree. But our cots do not go beyond a 90-degree seat. And some patients are going to want to sit all the way up. Some patients are going to want to sit all the way up and put their feet on the floor on either side of the cot and lean forward. And that's still okay. We just have to apply our seatbelts as best as we can, allowing them in that position of comfort. The other thing we can do is if we have a patient who is an asthmatic or who has COPD or has some other medical condition where they have been prescribed an inhaler, we are allowed to assist them in administering that. Absolutely, because that may alleviate a lot of their symptoms. If you've got a heavy asthmatic whose fingers are tingling and they can't grasp their inhaler, well, we can do that for them and go ahead and get that medication in to alleviate some of their symptoms. The other option that we have is a CPAP. So that's that continuous positive airway pressure. And it's not just for, overweight middle-aged guys sleeping at night. This really can help a patient when they are in, a lot of distress and they need that positive pressure. You will find justification for a CPAP in a handful of difficulty breathing scenarios. Let's talk a little bit more about what CPAP is. So this is that mask that straps to the patient's face. It's considered non-invasive because it just sits outside their body. It's not an internal ventilating device. But it's positive airway pressure. So it blows our oxygen continuously at a reasonably low pressure to keep those alveoli in the lungs open. And if those alveoli are open, that means we can get that oxygen exchange still happening. The other thing that it can do is it can prevent fluid from entering the alveoli. So in pulmonary edema, in real bad pneumonia, those are situations where that fluid may get in there and kind of constrict those alveoli, and the CPAP is going to prevent that. We kind of already covered a couple of these, but reasons that you might use CPAP is going to be in that pulmonary edema, that pneumonia. You're also going to potentially consider it in situations where we've got asthma or COPD. There are some contraindications that are going to help you decide when it's an appropriate intervention to use. Another one you might use it in is respiratory failure. And you have to remember the definition of respiratory failure is the patient is having difficulty exchanging that oxygen. They can't take oxygen in and they can't blow carbon dioxide off. So in this particular case, we're not going to apply CPAP if the patient's not able to breathe on their own. So you're not going to use CPAP in respiratory failure nearly as often in some of the other cases. But one of the other times that you might use CPAP or you might consider CPAP is in a drowning patient. But again, that patient has to be able to take air in and out on their own. So maybe you have a drowning patient who you did have to bag, you were ventilating them with a BVM, but now they're breathing on their own. Well, now might be a time to consider that CPAP, kind of help them get that fluid pushed out of their lungs, keep those lungs open. Okay, so we talked about when we do want to consider CPAP. So let's talk about some of those contraindications for when we don't want to use CPAP. So that's going to include a patient with severely altered mental status. And the reason you're not going to want to use CPAP in a patient that's altered is for a couple of reasons. One of those reasons is because they may not comprehend what the CPAP is or why you're going to strap it to their face. And that's going to cause patient distress, which is going to make their breathing worse. So it's not actually going to help you in the end anyway. Another reason that you might not use it in a severely altered mental patient is because part of the reason that they're altered might be because they're hypoxic. And if they're hypoxic, that CPAP is not what you need. You need to elevate that care into that assisted ventilation. Another reason that you might not use it in a severely altered patient is if they are severely altered, they may not be able to sustain and protect their own airway. Well, if they're not able to do that, we don't want to put a CPAP on them because they're not going to be able to breathe normally. So another contraindication would be a lack of normal, spontaneous respirations. So if they're not breathing on their own, again, that's inadequate breathing, we're going to jump to those assisted ventilations. If the patient cannot sit up on their own, that's a good indicator that this may not be for them. A CPAP applied to a patient who is lying down is never going to be as efficient as a CPAP applied to a patient who's sitting up. Again, we need to be able to protect that airway. Another reason you might not consider CPAP might seem a little bit obvious, but it's when you have hypotension, so low blood pressure, or if the patient is already in shock. Again, this circles all the way back around to being able to protect that airway. Obviously, we also have some pretty practical contraindications. If the patient is nauseous and vomiting, we do not want to strap a mask to their face that can't be moved easily. The other time we don't want to use a CPAP is if there is any kind of severe chest trauma, because if we have weakened the walls of the chest in some way, like if they were in an MVC and they hit the steering wheel, or if they have some sort of a penetrating chest wound, all that your positive pressure airway is going to do is just leak that oxygen back out into the atmosphere through whatever trauma that patient has. We mentioned shock already, but an interesting one is also an upper GI bleed or some kind of a recent gastric surgery. Because a CPAP is a positive pressure device, the CPAP machine does not differentiate between an esophagus and a trachea. And so if that patient stops maintaining their airway, even for a moment, we can force air into their stomach. Now, if they are maintaining their airway and they are conscious and they are fine, then they are going to be able to prevent that themselves. However, if they do have that recent upper GI bleed or they do have that gastric surgery, what that can do is pop those stitches or make that bleeding, restart or recur with that positive pressure, and we don't want to do that. The other time we don't want to use a CPAP is going to be if we can't get a good face seal. And that does not mean that you can't get a good face seal on patients, male patients that have thick facial hair. You can still sometimes get a pretty good seal on those patients. Obviously, you're still going to want to try. What this is sort of more talking about is if there's any kind of facial trauma. Obviously, again, you are not going to want to strap a mask onto that patient. So if they were in a car accident and they hit their face on a steering wheel and they've got that facial trauma, if you're going to make it worse by strapping a CPAP machine to their face, consider that BVM instead. So we've given our patients some CPAP O2. Let's talk about those side effects. Possible side effects of CPAP, we've got hypotension, so we've got that dropping of that blood pressure, a pneumothorax, so this is why we want to be very careful with those patients that have possible chest trauma, because we can cause the collapsing of a lung if the chest cavity is not able to maintain that pressure. We also have that increased risk of aspiration, so if we do pump air into a patient's stomach and they vomit, we've got that aspiration risk. The other possible side effect is drying of their corneas. So, we avoid that by making sure we have a good mask seal. For patients that have never used a CPAP before or don't know what it is, it can be a very claustrophobic feeling event. So we definitely want to kind of over-explain to the patient what's going to happen. We show them the mask. You want to show them the straps that are going to go around their head, how it's going to go around their head, maybe how it's going to feel a little bit. Explain to them that this is going to push air. It's going to give you air all of the time, but you're still going to have to breathe with it. And then when you go ahead and put them on the CPAP, go ahead and start them out with that low level of pressure, because you can always increase. It's a lot harder to come back down off of that pressure. And this is what I mentioned a little bit about. It may cause the patient to have a little bit of anxiety, maybe a little claustrophobic, may make them feel a little bit smothered. So over-explaining what's about to happen is kind of ideal. So when we put the mask on, it is going to push on their face. It may be uncomfortable. Patients that are wearing glasses may have to take them off. These are all things that have to be considered in your explanation of the CPAP. Just like any other patient with any other intervention, if we have this patient on a CPAP, we're going to want to reassess regularly. We're going to talk about reassessing mental status. We want to check those vital signs. We want to make sure that their breathing hasn't changed. If their dyspnea is different. Obviously, patients that are on a CPAP have a little bit more of a difficult time communicating with you and answering your questions. So we want to double check that. So if we've had them on the CPAP for a couple of minutes, it's completely fine to go ahead and pull that mask off in order for them to answer a question for your reassessment purposes. Because before you put the CPAP on, if they were only able to give you 1 or 2 word sentences, and then they wore the CPAP for 3 or 4 minutes, and now you're doing a reassessment, if now they can get 7 or 8 words in between breaths, that is patient improvement. So we want to see that. Obviously, if no change, we're going to want to increase that CPAP level after a few minutes. Since we have been excellent EMTs up to this point with our monitoring and our reassessing of our patient, we are going to be able to catch if our patient starts to deteriorate. And if they are already in a CPAP, then the next level of care, sort of the upgraded level to that, is going to be that bag valve mask. So if the CPAP isn't working and your patient's condition starts to go in the tank, we're just going to go ahead and remove that CPAP and we're going to begin ventilations. And that means that if you applied that CPAP and then you went to do your reassessment a couple of minutes later and nothing has changed, you might increase your pressure, give it a couple more minutes. But if after that first assessment you have noticed that your patient is starting to deteriorate and they're no longer conscious, or their mental status has changed, or they did have 5 and 6 word dyspnea and now they have 1 word dyspnea, we need to increase our level of care here. So once again, this is where our inadequate breathing comes into play. If they're on the CPAP and their breathing becomes inadequate, if they lose consciousness, if for some reason they can no longer maintain the safety of their airway, we're going to go ahead and take that CPAP off and we're going to switch over to that BVM. Now we're going to cover some more of the common respiratory conditions that you're going to see in the field. This is obviously not an exhaustive list. These are just some of the more common ones. First up, we have COPD, that is chronic obstructive pulmonary disease. So it's sort of an umbrella terminology for a couple of other things. You're going to find emphysema under this umbrella. You're going to find chronic bronchitis. A lot of, if doctors don't really know what's wrong with you, but you have difficulty breathing all the time, they may just say that you have COPD. A lot of COPD is caused by smoking. So under the COPD umbrella, we have something called chronic bronchitis. So that's actually where the bronchioles themselves have an inflamed lining. What that's going to cause is a whole lot of extra mucus. This is going to be apparent in your patients that have that very wet cough all of the time. So you're going to hear this in smoker's cough, if you know what that sounds like. That's what that is that extra mucus production in the bronchioles. So you have special cells in your lungs whose job it is to push mucus up and away so that you can cough it out and get rid of it. And in chronic bronchitis, they're not able to do that. This diagram is giving us a pretty good example of the difference between normal alveoli in somebody with chronic bronchitis, and then a patient with emphysema. So in the first picture, you're going to see those are just normal alveoli. That's what they're supposed to look like little bunches of grapes or what have you. And then in the center, you're going to see that chronic bronchitis. So all of that mucus sort of drips down and gathers in places, and suddenly those alveoli can no longer operate. They can't exchange any oxygen at the cellular level because they're just full of snot, really. And then lastly, in that emphysema picture on the far right, what we actually have is decreased surface area. So the definition in between each of those alveoli is sort of just going away. And so with less alveoli and less surface area, we have less opportunities for that cellular exchange of oxygen. Conveniently, we mentioned emphysema. So the alveoli walls are breaking down. Like we said, that surface area gets lost. And with loss of surface area, we've lost the ability to exchange oxygen. The other thing that happens with emphysema is you lose lung elasticity. So it's not as easy anymore for your lungs to bounce back after every breath or increase with every breath. They've sort of lost that elasticity, which is going to increase the work that it takes to breathe in and out. So what that ultimately leaves us with is a lot of extra carbon dioxide just getting stuck and hanging around in the lungs, and the patient's not able to breathe it off. They're not able to get rid of it. So now asthma is defined by being a chronic disease with episodic exacerbations. So what we talk about when we're saying they had an asthma attack. That's what that is. And the triggers for asthma attacks are very different. It depends person to person, patient to patient. Some asthmatics will have an attack due to excess exercise. Sometimes it's, grass clippings. Sometimes it's wood smoke. There's no overall, one thing fits everybody sort of situation. However, every asthma attack is caused by the same thing or does the same thing. And what that means is during the asthma attack, you're going to see those small bronchioles narrow. That's what we refer to as bronchoconstriction. And then we're also going to see an overproduction of mucus. So when those two things come together, we're going to have a severely restricted airflow. And in asthma, we're going to be able to hear that restricted airflow. So the specific sound that an asthmatic will make in the middle of an asthma attack is due to when an asthmatic inhales through those narrow airways, their lungs are going to create that negative pressure. So those airways are going to come open. The problem arises is when they try to exhale, now that pressure isn't there. We have that passive expiration. So what we're going to hear is an audible wheezing on exhalation. So inhalation is going to be quiet and you're not going to be able to hear it. And then the wheeze is going to happen on exhalation. So that's the opposite of when somebody has an obstruction. So if they're choking on something, you might hear that inhalation wheeze. With asthmatics, you're going to hear the opposite. You're going to get that wheeze on expiration. With pulmonary edema, we're going to get some abnormal accumulation of fluid in the alveoli, which I enjoy the way that they have to say it, because there's no amount of fluid that is normal to accumulate in your alveoli, so I find it funny. But we're going to see this a lot in patients that have CHF. So if you go to a patient's house and they report that they have congestive heart failure, when you listen to those lungs, this is definitely going to be a thing that you're going to want to pay extra attention to. You want to make sure that that's not what you're hearing. And pulmonary edema is going to sound a whole lot like those Rice Krispies that we talked about, those crackles, where you're hearing the fluid normally in the bottoms of the lungs, the lower sections, but if it's real bad, you can hear it in the upper sections as well. But it's going to sound like crackles. You're going to hear that fluid moving around with their breathing. Specifically in pulmonary edema, what you're going to have is that pressure building up in those pulmonary capillaries. And then because of that pressure, fluid is going to cross the barrier between the body and the alveoli. So you're going to get that fluid, interstitial fluid, if you will, if you remember back to A&P again, is going to cross that barrier into the alveoli. And so once you have fluid in there, it's going to make it really difficult for those oxygen exchanges to happen. So you're going to get dyspnea, you're going to get hypoxia, you're going to get the cyanotic lips, things like that. A longer list of signs and symptoms in pulmonary edema is also going to include things like anxiety. Patient is going to be pale, maybe sweaty, might have some tachycardia going on, you might see some hypertension, but you're also going to see respirations that are rapid and labored. That's an important combination there in the identification of pulmonary edema. And while a patient may not have all of these symptoms, or only some of these symptoms, or only one of these symptoms, respirations being rapid and labored together is a pretty good indicator. Obviously, you're also going to see that low oxygen saturation. A couple more signs and symptoms that you might see in a patient with pulmonary edema is going to include the possibility of that gurgling sound. And remember, we sort of differentiated that gurgling sound with if you're using a straw and you get to the bottom of your cup and you're trying to get the last few drops, that's kind of what that sounds like. And then we're also going to hear those crackles that we talked about. And then even sometimes you might get some wheezing. but it's a little bit different from an asthmatic wheezing or from an obstructive wheezing because you're going to hear it on inhalation and exhalation. It's going to be sort of all the time. Patients may also, if they're coughing, if they have a productive cough, you may also be able to identify some frothy sort of wetness at the corners of their mouth. It's usually white, can sometimes be pink. But again, that's assuming that they're actually producing a frothy sputum when they cough. We're going to treat pulmonary edema the same way that we're going to treat any sort of breathing difficulty. We're going to do our assessment first. We're going to make sure that they have adequate breathing. If their breathing is inadequate, then we are going to move on to our treatment plan. So always that high concentration oxygen. We are going to, if possible, again, position of comfort first, but if possible, we like to keep those patient legs in the dependent position so that their body is not having to work as hard to circulate all of their blood quite as far. We also can consider a CPAP. We mentioned that earlier when we covered the CPAP, but it's really good to push those fluids back out of the lungs. So this is an interesting topic to think about because when we talk about medical conditions, we tend to talk about one at a time, but patients very rarely ever have one at a time. So in a respiratory patient, could they have multiple respiratory disorders? And if so, what might they be? How might that affect their respirations? So could a person with an underlying diagnosis of COPD also be diagnosed with pulmonary edema? Pretty much far and away, I think pneumonia is the most common COPD complication that I have seen in the field. And it is caused by a bacteria or a virus, sometimes even a fungus that a patient has come across and has inhaled into their lungs. And what happens with any other infection is we get a bug and it grows and it causes that inflammation. So in this particular instance, it's just, it grows in the lungs. As far as pneumonia is concerned, it might be one of the more common COPD complications that I have seen in the field. And it's identified by that shortness of breath, with or without exertion, coughing, fever, and maybe chills. Remember, pneumonia is an infection. It doesn't always have to be the primary infection. It may be a secondary infection. You may have had a cold and now you have pneumonia. So it may be a secondary infection, but it is an infection. So we still have that inflammation. We still have that immune response. We're still going to get that fever, possibly with the chills. We may also get some chest pain in these patients. They may also complain of a sharp or stabbing pain, usually with inhalation, because they're kind of stressing out those already full alveoli. And they'll complain that the pain is pleuritic, so sort of in the lining of the lung, which is really difficult to describe. We're also going to see all of the normal signs of an infection. We're going to see a possible headache, pale, sweaty skin, fatigue, possibly some confusion. But treatment for pneumonia is pretty supportive. There's not really a whole lot we can do for infections in the field. So we're looking at alleviating as many symptoms as possible. Obviously, first thing we're going to do is we're going to assess that patient. We're going to check for adequate breathing. Assuming, of course, that your patient is breathing adequately, then you're just going to provide comfort care. If the patient, however, is inadequately breathing, if they're hypoxic, we're going to get that extra O2 in there. We're going to start talking about treating the inadequate breathing. Do they need assisted ventilations? Do they need CPAP? That sort of thing. Sometimes pneumonia by itself can be enough to cause inadequate breathing. Not always. So don't necessarily assume if you hear pneumonia and you've diagnosed pneumonia in your patient that at some point in your transport it's going to become inadequate breathing, because that's not necessarily the case. You're going to reassess that patient every few minutes, So you're going to have a good idea of whether or not that patient's pneumonia is going to escalate their difficulty breathing. Spontaneous pneumothorax is interesting because it's when a patient's lung collapses without injury. So there's no other obvious cause, just all of a sudden a patient's lung chooses to collapse. So obviously there are people that are a bit higher risk for this sort of thing happening. We have the patients with COPD, we have the patients with a history of smoking. Obviously they're going to be at higher risk. However, specifically, we also see people that are very tall and very thin. They have to be both of those, but if they are, they're actually at pretty high risk for this spontaneous pneumothorax, more so than the regular population. Signs and symptoms of your spontaneous pneumothorax are going to include sharp pleuritic chest pain. Then they're going to include a whole bunch of symptoms that could be attributed to other things, like shortness of breath, low oxygen saturation, easily tired, except in this particular case, your patients are easily tired because they have one lung doing the work of two. You're going to notice that cyanosis, you're going to have that tachycardia, you're going to have the fast breathing, potentially up to and including hyperventilation. But most definitively, you're going to have decreased or absent lung sounds on one side. As it gets worse, you're also going to see that JVD, that jugular vein distension, and the hypotension. The blood pressure is going to go down, the JVD is going to be apparent. By the time we reach this point, we're in sort of bad news. So treatment for spontaneous pneumothorax is going to be an ALS problem because we've got to get air back into the lung that's collapsed. We've got to get it reinflated. So for us, the EMT in the field, we're going to go ahead and call for that tier, and then we are going to go ahead and get that oxygen on board. We do not, however, want to apply a CPAP. For all of the reasons we talked about earlier when we talked about why CPAPs can be contraindicated, that applies here as well. So we're treating symptoms and we are transporting quickly. Pulmonary edema, not to be confused with a pulmonary embolism. A pulmonary embolism is a blockage in the blood supply to the lungs. Pulmonary edema is all of that fluid where the embolism is a blockage. So normally it is caused by a deep vein thrombosis, that's your DVT. And some of the common causes for DVTs are going to be lying down or sitting in the position for extended periods of time. People that have jobs where they sit, maybe they sit in an office chair for 8 or 10 hours a day, maybe they drive a delivery vehicle or they drive a semi. These are going to put them at higher risk for DVTs. But additionally, just having an active cancer puts you at higher risk. The same with, if you've broken a limb and they've had to cast it, you are now at higher risk because your circulation is not going to be the same while you're in that cast. Again, a lot of respiratory signs and symptoms are very similar. So we have to look for the special cues, the red flags for these things, because the most common signs of a pulmonary embolism are going to be that sharp pleuritic chest pain, that shortness of breath, the anxiety, the coughing, the tachycardia, the tachypnea. We've seen all of these in other respiratory emergencies. So we need to pay attention to the more fine details of the signs and symptoms because lightheadedness and dizziness, that might happen in other respiratory conditions, but pain and swelling in one or both legs, that's not common across the board. You might see some swelling in a CHF patient, but if we have pain and swelling, especially if it's only on one side, that's a pretty telltale sign. Again, we may see that hypotension. We may even see a cardiac arrest. It is insanely hard to diagnose a pulmonary embolism in the field. So ultimately, we are treating symptoms. We are looking at administering that oxygen. We are looking at symptom management, shortness of breath, right? We are, position of comfort. We are alleviating as much anxiety as possible. That's the sort of thing that we can do. So those are the sorts of things that we should do. And then obviously, we're going to transport to definitive care, to the closest appropriate facility. Epiglottitis is an infection of the epiglottis. If you remember clear back to med term, itis is anything that is inflamed. So in this particular case, it's the epiglottis that is inflamed, thus epiglottitis. So in this particular case, it is exactly what it sounds like. We're talking about an infection with swelling around and above the epiglottis. So then in severe cases, swelling can fully obstruct the airway. While any demographic is at risk of an infection anywhere, epiglottitis is normally seen more often in pediatric patients. And they're going to present to you with a sore throat, painful or difficult swallowing, that tripod positioning. They're just going to look sick. You're going to be able to look at that kiddo or even that adult patient and just be able to tell something looks off. They just look miserable. But also, they're going to have that muffled voice because it's their epiglottis that's inflamed, so they may not be able to talk at a loud volume or as clearly as they ordinarily would. It may also come with a fever. Again, itis, infection, inflammation. So we may have that fever on board as well. But one of the earmarks of epiglottitis is going to be drooling. Because the epiglottis is swollen, because the throat is probably painful, especially in pediatric patients, you're going to catch them tripoding with drool. And it is pretty easy to diagnose when you walk in the door and that is what you see. Lung sounds, however, we're going to be able to hear that stridor. Again, that stridor comes from that obstructed airway. Once again, we have a hard time doing infection treatment in the field. So our treatment plan for epiglottitis is going to be to keep the patient as calm as possible, especially in ped patients. They don't tend to like medical care ambulances anyway. And so the calmer we can keep them, the less likely they're going to be to cry. And if they cry, they're going to produce more mucus, more fluids, and potentially obstruct that airway even further. So the other thing that's super important is we are not going to ask to inspect their throat. We're not going to ask them to stick out their tongue and let us see, mostly because that's just undue distress to the patient and it's going to be uncomfortable and we can't fix it. So as long as we know that there is no risk that this is again, a potentially swallowed quarter, and we can see that they are tripoding, they are drooling, they have a fever, we can pretty much diagnose this as epiglottitis, and we do not need to see in their throat and cause that extra distress. If possible, if applicable, we can give oxygen if needed. However, if it's going to cause extra distress to the patient, we can do blow-by. We can have mom or dad hold if it's a pediatric patient. Obviously, adults tend to be a bit more reasonable, but whatever is the most comfortable for the patient. This patient may not want a mask on their face. So even if it's an adult, they may feel like they can't get air in, and putting a mask on, even though it's giving them oxygen, may make them feel worse. So again, in that case, we may consider something like blow-by oxygen. And then obviously, we're going to transport to the closest appropriate facility. Croup is going to be another one of those infections that is more common in children, however, possible in adults. So it is caused, again, by a virus. It is an infection, and it's going to cause inflammation in the larynx, the trachea, and those upper bronchi. So all of the tissues in that upper airway become swollen and then restrict air getting through. The earmark of croup is going to be a loud, barking cough that gets worse at night. We're also going to see a real hoarse voice because that cough is unavoidable. And usually we can alleviate a lot of symptoms just by sitting upright. Doesn't always alleviate those symptoms immediately, but they typically feel better sitting upright. So we're going to see the inadequate breathing in severe cases, and that's going to be indicated by our hypoxia, our cyanosis, our altered mental status, all of the signs and symptoms that we've already gone over as far as inadequate breathing goes. What we also may see is just signs of significant breathing difficulty, and that's when we're going to hear that inspiratory stridor. So stridor on inspiration, which is, again, if you recall, the opposite of asthma. So treatment-wise, we know this patient has croup, we've diagnosed it. But just like any other respiratory problem, if we have signs of inadequate breathing, it doesn't actually matter what the cause of that inadequate breathing is, we're still going to treat it the same. So we're going to go ahead and initiate those artificial respirations and immediate transport. However, if the patient is in respiratory distress but is breathing adequately, so they're maintaining their own airway, we are going to go ahead and call for that TEER. We're going to go ahead and call for that ALS, and we're going to initiate gentle transport. So we're going to go ahead and get on the road, but we're not necessarily going to have to go with lights and sirens. Obviously, we are also going to follow our vitals. We're going to follow our patient. So if they are hypoxic, we're going to go ahead and give them that supplemental oxygen. Again, super important, we're going to let that patient be in a position of comfort. Okay, so on to bronchiolitis. Again, we know itis is inflammation. This is literally translated inflammation of the bronchioles. So those are those small airways that have become inflamed because of an infection. So this is where we're going to see RSV, especially in little tiny kids. That's where this is going to come into play. Signs and symptoms of bronchiolitis. Very commonly, we have other cold-like symptoms. We have runny nose, we have fever, general lethargy, sort of those kind of all-the-time symptoms. The thing with bronchiolitis is you're going to see patients are going to report, or patients' family are going to report, that sort of has gotten worse and worse over the last couple of days, and now their breathing is worse. They have that wet cough, things like that. Another thing you're going to see is you're going to see multiple people in the household are going to be sick with the same thing. Super important when you have a pediatric patient to go ahead and look around at other family members, because especially in cases like RSV, which are more common in babies and kids under, I think, under 2, everybody else may just be presenting with the common cold, but then this baby has respiratory distress with that same virus. So in order to diagnose it, if you look around and everybody sort of has that red nose and is kind of looking unwell, it might be a good indicator that we're looking at something like RSV. Another thing that we can look for, that we need to be aware of, is that it can cause significant respiratory distress. And again, as we have said a couple of times, respiratory distress can lead to that inadequate breathing that we already talked about. Treatment, once again, similar to other things, this is an infection. So all we are going to do is we are going to treat symptoms. So if we find we have inadequate breathing, we're going to go ahead and assist ventilations. If the patient is hypoxic or shows sign of hypoxia, those are those, the cyanosis in those fingernail beds, the cyanosis around the lips, things like that, we're going to give that supplemental oxygen. If we have a baby, we might consider using a bulb syringe to suction that mucus out of the baby's nose. Remember, especially in babies, they are nose breathers, not mouth breathers. So if they have a stuffy nose and they can't breathe through it, they're going to be in a lot more distress than an older kid would, because an older kid will just breathe through their mouth. So go ahead and consider digging out your bulb syringe and clearing that airway. Another respiratory situation that we may not always associate with breathing difficulty is going to be things like cystic fibrosis. So this is typically a disease, a genetic disease that appears in childhood. And one of its common symptoms is going to be a thick, sticky mucus that accumulates in the lungs and in the digestive system. So the mucus is dangerous because it then becomes a breeding ground for infections in the lungs and then serious digestion problems. Parents that have a kid with cystic fibrosis and then subsequent adults that have it do know that they have it. So they're going to be able to tell you when you arrive on scene. So signs and symptoms that this may be a exacerbation of a cystic fibrosis issue is going to be coughing with just huge amounts of mucus. Just every time the patient coughs, they're going to cough something up. And then additionally, they're just tired, just fatigue. We're also going to have recurring pneumonia. That is also a thing that we see a lot. Again, if it's a kid, mom and dad are going to tell us that they have a history of pneumonia. They get pneumonia all the time, things like that. We also may see some abdominal pain with distension. So your secondary assessment and assessing of that abdomen is going to reveal that. Patient may also cough up blood. They may also be nauseous, but also they or the family may report that they've had some pretty significant weight loss recently. As with a lot of long-term diseases, if they're old enough, the patient themselves, or if they're too young, whoever their caregiver is going to be your best bet for how that patient is normally. And then that's going to give us a baseline for what to then go off of on our assessment. We may note that compared to normal, a blood pressure of 100/70 is a little low. But if their caregiver says that that is where their blood pressure is all of the time and that's normal for them, then that's normal. We don't necessarily need to worry about that unless it goes up or down significantly from there. Okay, so this is where we see the viral respiratory infection. It would be the adult equivalent of that RSV that we saw in infants a little bit ago. So our signs and symptoms of a viral respiratory infection, and remember, this is where we're talking about things like influenza or COVID even. So our signs and symptoms are going to be similar to what we find in the common cold. We have a sore, scratchy throat. We might have sneezing, runny nose, fatigue, possibly have fever and chills. That infection might spread then down into the lungs, which might cause a little bit of shortness of breath. We also may have a cough that's just persistent. It may or may not produce anything. If it does, though, it's going to be that yellow or greenish sputum that is indicative of an infection. So here we are again with our supplemental supportive treatment. Because we cannot fix an infection in the field, we're going to treat symptoms. So in this particular case, if we see a hypoxia, we're going to give supplemental oxygen. If the patient is wheezing, we might consider an albuterol treatment or assisting them with their inhaler or what have you. So because the infection is viral, antibiotics are not going to make a difference. However, you might get to educate a patient on how to prevent viral respiratory infections, even though we're now in the world post-COVID and everybody knows that good hygiene is where it's at. This may be your opportunity to have a conversation with that patient about how to prevent this type of thing. So for anybody who doesn't own or doesn't have somebody in their life that has an inhaler, we're going to talk a little bit about that now. So the way that a metered dose inhaler works is every time you depress it, it's going to give an exactly measured dose of medication for that patient to inhale. Now, it is most commonly prescribed for conditions causing bronchoconstriction, which is going to be things like that asthma. So if you're on scene and you have a patient that does own an inhaler, it's been prescribed for them, and you're going to assist them in administering it, we are going to do our med checks. So we're going to make sure it's the right patient, the right time, the right medication, the right dose, and the right route. And if it's been a minute since you went through all of that with our medication chapter, the right patient, that inhaler is going to have their name on it. The right time, make sure it's not expired. Make sure it's the right medication. Make sure it is the right dosage. Make sure that they are administering it properly. Obviously, an inhaler is going to go in the mouth and they're going to breathe it. But I have seen some crazy things in the field, and spraying it out in front of your face is not as uncommon as you'd like to think it is. So we're also going to go ahead and shake that inhaler pretty vigorously for a few seconds before we administer it. It just distributes that medication more evenly. And then we also have to make sure that the patient is alert enough to use their inhaler. A space saver is great if the patient has one. If not, it's not required, but it does make it a little easier to assist someone in administering an inhaler. So this is the spacer device that we were talking about just a minute ago. And what this really does, it just makes sure that that medication has a longer period of time to be inhaled. Because if the patient puts the inhaler directly into their mouth, they kind of have to be able to know how to use it in order to get the maximum amount of that medication directly into their lungs, which is where they need it. Whereas with this, you can depress that inhaler and the medication sort of hangs out in that spacer so that the patient can breathe at their leisure. It's just a little bit of more relaxed situation. You'll see these a lot more in pediatric patients. So when we go to assist a patient to administer an inhaler, the first instruction when you're ready to give it is to have the patient just blow all of their breath out. Because once those lungs are empty, they're going to want to breathe in much more deeply than they already were. So then you're going to have them blow that breath out, put the inhaler to their mouth, seal their lips around it, and you are going to depress that inhaler right as the patient starts to inhale. Like they start to inhale, and that's when you want to push the inhaler down. And then once they have inhaled that whole dose, you want them to hold their breath just as long as they possibly can. Sometimes that isn't very long. You know, if they're in the middle of an asthma attack, they may not be able to hold their breath very long, but you just want to make sure it's in there as long as possible. So now we're going to talk about the small volume nebulizer. What it does is it gives the same medications that you could get in an inhaler, but in a nebulized version. And all that really means is it just means that you are running oxygen or air through that liquid medication in order to vaporize it. And then once it is vaporized, then the patient breathes those vapors. And it's a little bit different to just a straight inhaler because with that, you're just breathing that medication in directly. And in this case, we're actually vaporizing it out into the air. So the nice thing about the nebulizer is that because it is continuously flowing that medication that's been aerosolized, then the patient doesn't have to hold their breath. They don't have to take as deep a breath. They can actually get that medication over several breaths in several minutes, which means they have a better opportunity to get more of that medication into their lungs and where it needs to be. So this is giving us a visual example of how we might apply a nebulizer. We like to have patients hold their breath, but realistically it isn't necessary, especially because a lot of nebulizers that we carry in the rigs now will also fit in an oxygen mask. They attach right to the oxygen mask, which means that all of that nebulized, aerosolized medication is got that extra second to hang out near the patient's nose and mouth, which again gives it that bigger opportunity to be inhaled where it's supposed to be. Okay, so we're already into our chapter review. So just to go over, respiratory emergencies are common complaints for all of the EMTs. It's something that we're going to see a lot of. So it's important that we understand the anatomy, what everything is, the physiology, how everything works, the pathophysiology, how everything works together, assessments for respiratory emergencies, and then how are we going to care for those patients with those things. So patients with respiratory complaints, and don't forget, they can be very closely related to cardiac complaints. They may exhibit inadequate breathing. If we know that, we already know what inadequate breathing means. We also know rapid respirations indicate serious conditions. We can have hypoxia, we can have cardiac issues, respiratory issues, and shock. Conversely, very slow and very shallow respirations are often the endpoint. They are typically a precursor to death. Hyperventilation isn't great. Hypoventilation is a huge red flag. So when we talk about our assessment, respiratory emergencies are yet another area where history can give us a great indication of what our diagnosis should be and then what our treatment plan should be. So in addition to that pertinent past history and those medications, the signs and symptoms of today's problem and then paired with our OPQRST are gonna give us a great indicator of that diagnosis and treatment plan. As with anything else, when we get our patient, we are going to want to physically examine the point of issue. Whatever the problem is with that patient, we are gonna want to examine that area of their body. So if they're having a respiratory issue, this is when we examine that. This is when we assess that. We're talking about work of breathing. We're going to talk about inspecting their accessory muscle use, gathering those pulse ox readings. We want to make sure that we've got adequate and equal lung sounds on both sides. Are there excess fluids in the patient's body, their belly, their feet, their ankles, in their lungs? Can you hear it? And then we're going to pair all of that with our vital signs. So since we're reviewing, we know that there are several medications that are available to help a patient's difficulty breathing. Take a second and think about what those are. Also, remember that we are determining if a patient's breathing is adequate, inadequate, or absent altogether. If they are one of those three things, we need to choose the appropriate oxygen level and ventilation level, if any. So when we're considering whether or not to assist a patient and administering their respiratory medications, remember to ask yourself, do you have protocols and medications that will help this patient? Does the patient have a presentation and condition that fits those protocols? With that, we also need to consider if there are any contraindications to using those medications in your protocols and what they are and whether or not they will apply to our patient. Something to consider. I really like these questions. This one says, what would you expect a patient's respiratory rate to do when the patient gets hypoxic? So would you expect the respiratory rate to go up or to go down? So why do you think that? Another thing is, what would you expect a patient's pulse rate to do when the patient gets hypoxic? Would you expect their heart rate to go up, or would you expect their heart rate to go down with their oxygen level? Why do you think that? So now think about listing the signs of inadequate breathing. I love this question. Would you expect to assist a patient with their prescribed inhaler when they are experiencing congestive heart failure? Why or why not? List some differences between adult and infant or child respiratory symptoms. Think back to that slide. Think about the differences between the two. So now this is a little critical thinking patient scenario. You have a 72-year-old female who's complaining of shortness of breath, and her husband notes that she seems very confused. You do your assessment and you note a respiratory rate of 8 breaths per minute and you note cyanosis. The patient has a history of COPD and CHF. So think about the treatment steps that you're going to perform in order to assist this patient.